I think next we have a prolific surgeon and who's also a pan-ophthalmologist, who is none other than Dr. Upsham Goel, sir, who is a specialist in cataract, refractive, and VR surgery. Is the director of TC Eye Center. Over to Dr. Upsham, sir, please.
Thank you, Shri. Just share my screen. Yeah. So hello, everyone. So we are looking at the OCT now, and along with the OCT, let's look at the role of OCT biomarkers, because as we all know, that quantifiable medical science, which are what biomarkers are, have become of great relevance in all clinical practice and research. Because while OCT has given us a lot of good quality images, the value of what it is showing us needs to be really understood. Because right in the early days of OCT, because we were among the earliest people to acquire this technology in India, HDOCT, and there was so much data being thrown up, which we didn't really know what to do, entirely do with it. So now just over to the simple the image. Okay, are my slides moving?
Yes.
Okay, fine. So we have the normal anatomy, which we correlate with the OCT anatomy, and we are looking at some of the biomarkers as to when to look at a patient's OCT, when to be able to tell him that, okay, we think that the prognosis may not be as good as we think.
So sorry to interrupt. Can you put it in slideshow mode?
I'll try that, but sometimes it doesn't move forward. Okay, I'll just try that. And now again, are my slides moving now?
Yeah.
Yes, they're moving?
Yes.
Okay. So one of the biomarkers is the central subfield thickness. So a lot of these, what we call as biomarkers, are actually pretty obvious. It's self-explanatory, I would say, because the fact that why is fluid there? Let's look at that. Why is fluid there? And what is the normal anatomy? So naturally, anything that disrupts the normal anatomy will obviously cause a damage to the visual pathway itself. So similarly, the central subfield thickness, and it can be because of the presence of fluid, where obviously the greater amount of fluid and the greater the fluctuations, this would be the outcomes. And CSFT value may be high in the presence of epiretinal membranes and other fibrotic kind of a thing. So it is not just fluid, it may be abnormal tissue, drusen, fibrous deposits, and so on. Now, risk factors for development of geographic atrophy after treatment with anti-VEGF include the presence of focal fluid. So that's something we have to understand, that all drugs or anti-VEGFs can finally lead to geographic atrophy. And it's kind of a problem, because if you don't treat, again, you'll end up with fibrosis and geographic atrophy. And if you treat, then the drug itself can cause damage. That's why most people like to treat and extend as the disease requires it. Approximately 38% of subjects in the CAT study developed geographic atrophy after 5 years. And of course, there was some difference in the various drugs that were being used. And now, in case of geographic atrophy development, naturally exactly, that's what I thought, man. That's what I was saying. That unfortunately, I don't know why I have to be this mode. So is that okay? Is that okay? Now the slides can move.
Yeah.
Okay. So in case of geographic atrophy development, the whole retina. So now, one of the speakers was talking about on-face versus cross-sectional. We not only do on-face and cross-sectional, we do OCT angiography for all our patients, because we think that looking at the vessel is very, very important. But all patients have to have the on-face along with the cross-sectional. Why? Because it gives us almost a holistic picture. I don't even have to look at the volume data. I just have to look at the picture on face, and we see it on cross-section. And then we see, and in exactly this kind of condition, where you have treated the patient for a long period of time, and there's a geographic atrophy developing, all the retinal layers thin out, and therefore naturally a very thin central subfoveal thickness will also mean a significantly lower visual acuity. The intraretinal cysts are, I mean, of course, we know primarily there are two fluids that we'll be looking at: the intraretinal fluid as well as the subretinal fluid. And IRCs are are the worst fluid to have. They can go away more easily, but they are the worst fluid to have because they normally would be associated. Why? Because there is a greater disruption of the anatomy of the retina itself. That's the basic issue. All the inner retinal fibers and all the inner retinal elements, they start getting more damaged because of the presence of the IRC. There may be different types. They could be oval, etc., or they could be more round, and they could be more square kind of a shape. And it could be because of exudation, and sometimes they can be because of the degeneration in the RP itself. The exudative cysts are active, are coming through active fluid exudation and are larger in size, and they are more oval shaped. After several months of injection, if you still have IRF, then these kind of patients would have naturally a high risk of developing fibrosis and RP atrophy compared to the refractory SRFs. And the subretinal fluid is a hyperreflective fluid accumulation overlying the RP layers. And it resolves in response to anti-VEGF, though it may not respond as quickly to as IRF, but there's interestingly, maybe we don't know, it may actually lead to provide some degree of protection to the fibrotic changes that may occur after the fluids are gone. So it is believed, because there were many talks about how much fluid will we tolerate. So it's agreed that IRF is something, intraretinal fluid is something you will not tolerate, and subretinal fluid is something which, if it is really not going away, then you may leave it alone. Because trying to remove that little element of fluid may actually cause more damage to the, because of mitochondrial apoptosis, which takes place with every VEGF, it may actually.
You need to mute yourselves. Yes. Yes. Yes, Doctor.
So and the pigment epithelial detachment is some RP fluid separation. We have already, other speakers are talking about in greater detail on that. And again, PD itself per se, the most important thing is PD per se. I would love to treat the PD. I would love to see it go, and I would love to use that VEGF which can make it go. If in case they stay, and in case they are not responding, and the visual acuity is better in a patient, I would probably think of accepting that fluid. SRF located on top of a PD instead of on the edge, PD may not, it may show that the PD may not be vascularized and may respond poorly to therapy. Whereas once the SRF is on the side of the PDs, then that means they would normally respond pretty well. Now, a very important thing which has taken the center stage is disorganization of the retinal inner layers. Again, like I said, most of it is based on common sense, that you have the ganglion cell layer and you have the right up to the outer plexiform layer. Now, if there is a disruption here, and especially in this layer of the inner nuclear layer, where there's the amicrine and the mular and all these cells, if there is fluid accumulation there, if there is a damage to that layer, then because these are a lot of role of all these cells is not even known thoroughly. But what we do know is that there's a lot of cross-sectional transmission of data from one cell to the other, and it is not a parallel process which like happens in the older computers. It is transmitting data from one cell to another across, and that's why this could be one of the reasons why the data transmission is faster, and this layer is very, very important and has a very important role in that. So disorganization in this layer can cause a definite long-term damage, and that's why it is assessed independently of presence of retinal edema, and it leads to the damage to the bipolar cells, and therefore represents an anatomic interruption to the visual transmission pathway itself. A chronicity of presence of DRIL is obviously something which is not a happy situation. And foveal DRIL is obviously, which is affecting more than 50% of central 1 mm, would obviously cause a worsening outcome. Now, another interesting thing is a lot of these biomarkers, what we call as biomarkers, a lot of them improve after VEGF therapy. And different VEGFs seem to have a different role in the quality of the return to normalcy of these biomarkers. And along with that, then is the disruption of the external limiting membrane and the OSIS junction. This is self-explanatory naturally, where you have the photoreceptors. If there's a disruption there, then obviously there would be loss. I don't know why people call it the ellipsoid zone. I still love to call it the OSIS junction, because the simple fact that it explains to you where the damage is actually taking place. So naturally, again, impairment of the ELM and OSIS junction in the central 1 mm would cause a worse visual outcome. The external limiting membrane, a damage to that seems to be a worse prognosticator than the damage to the to a short-term damage to the photoreceptor tips itself. And the destruction of ELM reflects impairment of the photoreceptor nuclei and severe retinal damage, whereas OSI's damage can, to some extent, be recovered with treatment. Then another important thing is the hyperreflective spots. HRS are like, like dead soldiers in a battle. So when you look at HRS, you know that either the battle has been fought pretty severely, but overall, if they are there, then it's a little ominous. The presence of HRS is a little ominous, and these are the patients which we would love to treat in a more aggressive manner, because once they start coming into the picture and they are increasing, then they can prognosticate a worsening of the condition. HRS seems to increase with progression of diabetic retinopathy, which is a close relation with the degree of retinal inflammation. And some believe that the HRS-F or the HRS, what do you call them, they may coalesce into becoming hard exudates later on. So several studies have shown rapid and significant decrease in HRF in patients who received anti-VEGF injections. Some people believe it works better with dexamethasone, but then that was in comparison to the older VEGFs. The newer VEGFs have very, very powerful action. Eyes with treatment naive DME and eyes where HRS was associated with NSAIDs at baseline responded better. Again, like I said, the presence of HRS itself is an ominous sign. So these are some references, and thank you so much for your patient hearing, though I was not able to give you a full slide views. Thank you so much.
Thank you. Thank you, Dr. Upsham. That was a very informed talk. Srinivas and Dr. Jatinder, could you take the questions? We need to, Dr. Lalit has joined. Very warm welcome, Dr. Lalit. I know you are driving for a meeting. I think we should capture him and Dr. Muralidhar in this question set. Dr. Lalit, you have to unmute yourself.
Yeah.
Warm welcome.
Hello, sir.
Hi, everybody.
Yeah.
I hope you're not driving.
Dr. Srinivas, would you take your first
Yes,
question?
madam. Yes. I just want to ask this question to Dr. NSM sir and Dr. Jay Chablani, who has just joined, and also Lalit sir. Welcome to the ARC webinar. What is this? The importance of this BRP, that is the bridging retinal process, and the SSPIM, which is also considered as an OCT biomarker, that is the suspended particle in motion. So, what is the relevance of these in real clinical applications?
Lalit, sir,
are you talking about vascular block? I just overheard. I just
No, I think this. This is
the question is about non-perfusion, or I didn't.
No, sir. SSRM he's talking about.
SSB. I think this is to Dr. Jay Chablani. I think you can just answer this if you can, please.
So what I couldn't hear the whole question, but yeah, about the SPIM, I think this was introduced much earlier, maybe around 4 or 5 years ago, where we were looking at OCT angio, and we were trying to see that what kind of cystic changes we see. In those cases, there was some hyperreflectivity seen, or because it was OCT angio, so there were hyper dots which were considered as moving particles. In fact, those particles were also reported in one of the AIOS paper, even on the structural OCT back in 2016. So what we thought is that it primarily depends upon the content of the cyst, which actually has, if it is a very turbid fluid, then you can have a motion particles, which gives you something called a SPIM. And But obviously, we still don't know its clinical significance for us, but we believe that if you see SPIM, then it is more of an exudative kind of fluid, which primarily happens in patients with DME, and sometimes we see also in BRVO. I don't want to take up all the time for discussion. Anybody else has any quick comments?
Yeah, normally once you see these particles, then it like you said, it tends to tell us that the prognosis may be worse. But again, there's a lot of variability, so you cannot reproduce the same finding from OCT to OCT since they're swimming around. So that's one thing you have to keep in mind. But the fact that they're there itself means that we could be looking at a worse prognosis.
Dr. Jatinder?
Thank you. So I just have one question. I think this question has been puzzling me for a while, and I think Dr. J or if anybody else is willing to answer this. Dr. Parveen is there. Welcome, Dr. Parveen. This doubt that I have is regarding this importance of intraretinal fluid as a biomarker. So whether intraretinal fluid itself is the cause of the visual prognosis being not so good, or is it just a part of the phenotype of the disease that is anyways has a poor prognosis? Jay, one very short answer, and then Dr. Parveen, can you just put a light on this?
A very interesting question, and I know that recent publications are showing that. So if I really have to use one line, I would say that if you are seeing chronic IRF, then definitely it is a poor prognosis factor. In cases when you have a newer naive cases, and if you see IRF, then we know that they are going to respond really well. But if you see an AMD with a long-standing IRF, it is a poor prognosis factor.
Dr. Parveen, are you there?
Yeah, so I think I agree with Dr. J. So we have these intraretinal cysts, and we, as Dr. J has mentioned, we divide them into the exudative and the degenerative ones. So exudative ones are the ones which are present early on in the course of disease, and they respond better. But if there are large degenerative ones, so they will not respond to treatment. Either way, answering Dr. Jitinder's question, I think I always look at it in a stepwise pattern, that most of these biomarkers are described in relevance to a type 1 CNV. And this type 1 CNV, you have it below the RPE. So the first thing when it presents or with activity is exudation, and you have subretinal fluid. And the next step is that now the fluid or the exudation starts happening into the substance of the retina. So by the time you have IRF, it is actually into the second level of activity, I would say. So that itself would make it probably a poor prognostic sign. And then it is causing you disruption of the nuclei, the nuclear layer and the plexiform layer. So you may have a permanent damage to the synaptic junctions which are there. So then the response to treatment, even if it happens, visually the patient may not benefit. This is how I understand the thing. As long as you see subretinal fluid, the neurosensory retina itself is very compact and the anatomy is not distorted. But once you see IRF, the anatomy of the cells gets distorted, which results in poor prognosis.
Thank you, Dr. Parveen.